welcome to this Ausmed lecture on hypovolemic shock, part 3 in our shock series. My name is Joanne Reading. I am a clinical nurse educator at one of Australia's biggest tertiary ICUs. I've spent over a decade gaining experience and expertise managing critically ill patients and have a passion for teaching clinicians to do the same. What we'll be looking at today is the causes of hypovolemic shock, signs and symptoms of hypovolemic shock, and the management of hypovolemic shock. So let's talk a little bit about definitions. Shock is an acute, widespread reduction in an effective tissue perfusion that invokes an imbalance of oxygen supply and demand, anaerobic metabolism, metabolic abnormalities, cellular and organ dysfunction, and if prolonged, irreversible damage and death. Hypovolemic shock is the above pathophysiology being set into motion secondary to the preload status of the circulatory system. If you would like further information related to what is preload and its relationship with contractility and afterload in different states of shock, please refer to part 2 of this lecture series, the relationship between preload, contractility, and afterload. To recap from part 2, hypovolemic shock is due to an empty tank making the primary problem preload. An empty tank leads to a non-functional pump, therefore a secondary problem of contractility, and this leads to the pipes tightening up, resulting in afterload becoming a compensatory mechanism. The pump will also speed up as a compensatory mechanism, so your heart rate will go up. Hypovolemic shock is caused by whole blood loss, conditions that result in the loss of blood from the intravascular department, and plasma fluid loss, conditions that result in the depletion of fluid within the intravascular department. There are various conditions that will result in whole blood loss, including open wounds and obvious external bleeding, internal bleeding into the abdominal or thoracic spaces, hemothoraxes, cardiac tamponades, a lacerated liver, spleen, or kidney, gastrointestinal hemorrhage, retroperitoneal bleeds, ruptured abdominal aortic aneurysms, trauma to bony structures, so something like our humerus can hold up to 500 to 1,000 mils of blood, tibias and fibulas, 750 to about 1,200 mils, femurs, 1,000 to 1,500 mils, and pelvis can hold up to about 1,500 to 2,500 mils. So you can imagine trauma to these bony structures, you can start to lose a lot of blood very quickly. And finally, ectopic pregnancies. There are various conditions that will result in plasma fluid losses, including excessive diuresis, dehydration, excessive diaphoresis, excessive or prolonged vomiting, diarrhea, nasogastric, fistula, and or stomal losses, and conditions that predispose the patient to something known as third spacing, which is the movement of fluid from the intravascular department into the interstitial department, where the fluid tends to be useless. We want fluid sitting in our intravascular department. That's what gives us bang for buck with our blood pressure. The second it moves out, that just is what creates the edema that we see within patients. Conditions that predispose the patients to third spacing can include sepsis, systemic inflammatory response syndrome known as SIRS, anaphylaxis, burns, peritonitis, pancreatitis, and extensive trauma. The signs and symptoms observed in hypovolemic shock will be centered around the clinical profile seen in this shock state. So remember, in hypovolemic shock, we have a low preload, an empty tank, low contractility, an ineffective pump, and a high afterload, tight pipe. So I want you to remember low preload, low contractility, high afterload. This is what your signs and symptoms are going to be centered around. So what does that look like? What do the preload manifestations in hypovolemic shock look like? These assessments may indicate that the tank is empty, a low central venous pressure or low jugular venous pressure, highlighting a reduction in intravascular volume. There could be a negative cumulative fluid balance, which takes into account the overall fluid status of the patient. So maybe this patient has been really diuresed. Low albumin levels may indicate there is insufficient oncotic pressure within the intravascular space that may result in more fluid getting stuck in the interstitial spaces without being able to be pulled back into the intravascular space. Remember, our oncotic pressure is what keeps fluid in the intravascular space. The second this starts to get diminished, fluid will move out. Peripheral edema, indicating there is an accumulation of fluid in the interstitial space, which can be used in conjunction with other assessments that indicate a low intravascular volume. Poor skin turgor or dry mucous membranes that could indicate cellular dehydration. And increased thirst, which is the body's way to indicate that it needs more fluid. So remember, preload, a low tank. These are the assessments that give you an indication there might be a low or empty tank. In regards to contractility manifestations in hypovolemic shock, these assessments may indicate that the pump is not optimally ejecting blood. Weak, thready pulses indicating there isn't a lot of fluid in the tank to be pumped out. And a tachycardia, which is the compensatory mechanism that we see within our body in a response to low contractility. Because if stroke volume is reduced, the body will try to increase heart rate to compensate for this. This is because our cardiac output is equal to our heart rate times our stroke volume. So when one goes down, the other must go up to try to compensate and keep that cardiac output the same. Lastly, let's talk about afterload manifestations in hypovolemic shock. These assessments may indicate that the pipes are tightening as a compensatory mechanism. We could see cool, clammy peripheries indicating vasoconstriction of the vessels to shunt blood from the peripheries to more important organs. We don't really need blood in our fingertips. We do need it in our heart, our lungs, our kidneys for us to actually function. Sluggish capillary refill and pale skin color, indicating there isn't a lot of residual blood in the peripheries as it's all being shunted centrally. So when we think about pipes being tightened, just think about blood being moved away from the peripheries into our central organs. Our fingertips, they're going to feel cool. Everything is going to feel a bit slower. That refill is going to be a bit slower because you don't have much blood sitting in that peripheral space. So now that we've talked about the signs and symptoms associated with hypovolemic shock, let's talk a little bit about management. Hypovolemic shock management is centered around two very important principles. Firstly, it's correcting the primary cause or causes where possible that resulted in the hypovolemic state in the first place. The second is restoring intravascular volume depletion. In regards to correcting the primary cause when dealing with whole blood loss, this is relatively straightforward while not always easy. It comes down to finding the source of the bleed and stopping it. However, conditions that predispose the patient to plasma fluid losses due to third spacing often require the condition to run its course. And that brings us to restoring our intravascular volume depletion. The key rule for restoring intravascular volume depletion is to fill the intravascular space with the fluid that has been lost. So when we talk about whole blood loss, this means we're going to fill with blood products. When we talk about plasma fluid loss, this means we're going to fill with something like an isotonic or a hypertonic fluid. And we'll talk about this in more detail. Let's start with blood product replacement. There are many different blood products that can be utilized to replace intravascular volume loss in a bleeding patient. We can have red blood cells, we can have pooled platelets, and we can have fresh frozen plasma. Now, of course, if your patient is actively bleeding and you need to go through a massive transfusion protocol, there are a lot more products that can be given, but I'm just focusing on the three main things that can double up as fluid replacement as well. In regards to fluid replacement, isotonic fluids include 0.9% sodium chloride, otherwise known as normal saline, compound sodium lactate, CSL, it might be known as Ringer's solution, and plasmolite. An isotonic solution has an osmolarity that is equal to that of the intravascular space, meaning that the fluid stays in the intravascular space to a physiological limit. Obviously, if I'm going to keep filling, there's going to be a point where that fluid needs to start pushing out into the interstitial spaces. It is important to note that if the patient is low on albumin and therefore oncotic pressure, or they are prone to third spacing due to a pathophysiological process that they are experiencing, this fluid will start to seep out into the interstitial spaces. And remember, hypovolemia is only going to be rectified if the volume is in the intravascular space. We need to restore fluid in the intravascular space, and we need to maintain the fluid in there. So as you can see, patients that are third spacing can be quite a challenge to manage. It can take a while. It's why we have to wait out the process of third spacing. We've got to fill, watch, and try to keep that balance going. This is also where hypertonic solutions can be useful. A hypertonic solution has an osmolarity higher than that of the intravascular space, meaning it will draw fluid into the intravascular space from the cells and the interstitial space. So these types of fluids could be useful if the patient has fluid on board, but in the wrong space. So when we say in the wrong space, we're basically meaning the interstitial space. This is kind of pointless space. It's somewhere between the cells and the intravascular area. It's where fluid has to pass to keep an equilibrium. But if it gets trapped in there, all it really does is cause edema. It doesn't give you any blood pressure. It doesn't give you any kind of hydration status for your cells. It's just wasted space. So if a patient is prone to third spacing going into that interstitial department, these fluids such as albumin, 4% albumin, 20% albumin, these fluids will help hold fluid in the intravascular space for longer. So let's talk a little bit about 4% albumin. These come in 500 ml bottles, and this fluid will pull 4 times the amount of fluid from the surrounding spaces into the intravascular department, if there is fluid to pull. 20% albumin, however, comes in a 100 ml bottle, and these are really concentrated formulas. So this fluid will pull about 20 times the amount of fluid from the surrounding spaces into the intravascular space. So you'll notice in a clinical area, you might see 4% albumin being given quite quickly, very quickly in fact, if you're trying to get fluid in there in a hurry, but you will never see 20% albumin being given as an open run. It's usually at least an hour that this is given, because if you pull fluid too quickly, you're going to create massive fluid shifts, and this can be detrimental to the patient. So a final note, the earlier hypovolemic shock is recognized and managed, the faster the cellular changes associated with shock can be reversed. So remember, the signs and symptoms will be associated with a low preload, an empty tank, low contractility, an ineffective pump, and high afterload, tight pipes. Management comes down to fixing the primary cause and replacing with what we've lost. Thank you for watching this lecture on hypovolemic shock. I hope you have gained some valuable insight into the causes, signs and symptoms, and management principles associated with managing this type of shock. If you enjoyed this lecture, I highly recommend watching the other lectures within this shock series. Thank you.